Good day, everyone. We are the third group and we are assigned to report the following topics: Peripheral Arterial Occlusive Disease by Miss June Cheryl Istalilia, Miss Jessica Cortezo, and Miss Shikaina Katendoy. Upper Extremity Arterial Occlusive Disease by Miss Clarice Joy de la Peña, Miss Angela Marie Cumagun, and Miss Mary Estelle Sintes. Thromboangiitis Obliterans by Miss Jessa Compendio and Miss Aya Abigail Cortel. Aortoiliac Disease by Miss Lara Flynn Cubero, Miss Bicham Dalugdog, and by Miss Billy Davis.
Peripheral arterial occlusive disease. Arterial insufficiency of the extremities occurs most often in men and is a common cause of disability. A peripheral arterial occlusive disease is a blockage or narrowing of an artery in the legs, usually due to atherosclerosis and resulting in decreased blood flow. The legs are the most frequently affected. However, the upper extremities may be involved. The age of onset and severity are influenced by the type and number of atherosclerotic risk factors. In peripheral arterial disease, obstructive lesions are predominantly confined to segments of the arterial system extending from the aorta below the renal arteries to the popliteal artery. Distal occlusive disease is frequently seen in patients with diabetes and in older patients. Peripheral arterial occlusive disease commonly develops in the arteries of the legs such as iliac arteries, femoral arteries, and popliteal arteries. Let's now head on to the risk factors. So, tobacco smoking might be one of the most important risk factors for the development of atherosclerotic plaques. Tobacco contains nicotine, which stimulates the sympathetic nervous system, producing vasoconstriction and decreasing blood flow to the extremities, as well as increasing the heart rate and blood pressure. It also raises the risk of clot formation by boosting platelet aggregation. Carbon monoxide, a toxin generated by tobacco combustion, interacts with hemoglobin more easily than oxygen, depriving tissues of oxygen. There is evidence that smoking reduces high-density lipoprotein levels and changes the ratio of HDL to LDL, HDL to glycerides, and HDL to total cholesterol levels. The quantity of tobacco used, whether inhaled in traditional or e-cigarette form or chewed, is directly connected to the severity of the illness, and quitting any sort of tobacco product use lowers the risk. Diabetes. Diabetes doubles or quadruples the total risk of peripheral arterial disease, with amputation rates 5 to 10 times greater than in individuals without diabetes. Diabetes patients have an earlier start and faster development of peripheral arterial diseases than non-diabetics. Moreover, they have a distinct anatomical distribution of pathology with a higher degree of illness in the profunda femoris and all segments below the knee. Diabetes influences the initiation and progression of atherosclerosis in a variety of ways, including the activation of inflammatory process, the disruption of numerous cell types inside artery walls, the encouragement of coagulation, and the suppression of fibrolysis. The black race. The black race has been linked to a more than twofold increase in the chance of having peripheral arterial disease as well as high rates of hypertension. Many additional variables also have been found as contributing to the illness process, including obesity, stress, and lack of exercise. CRP or C-reactive protein is a sensitive measure of systemic and localized cardiovascular inflammation. Slight increase in serum CRP levels are associated with an increased risk of vasculature damage, especially when combined with other risk factors such as increasing age, female gender, family history of cardiovascular diseases. Hyperhomocystinemia. It has been linked to an increase of peripheral, cerebral, and coronary artery disease, as well as venous thromboembolism. Homocysteine is a reactive protein that enhances coagulation by boosting factor 5 and factor 11 activity while inhibiting protein C activation and increasing lipoprotein binding in fibrin. This mechanism promotes the production of thrombin and proclivity for thrombosis. Although folic acid and vitamin B12 have been shown to lower blood homocysteine levels, there is no evidence that this treatment decreases adverse cardiovascular events. Let's now head on to the assessment. So, in assessing a patient with a peripheral arterial occlusive disease, they have a sensation of coldness or numbness in the extremities, may also accompany intermittent claudication, and is a result of reduced arterial flow. The extremity is cool and pale when elevated or ruddy and cyanotic when placed in a dependent position. Skin and nail changes, there might be ulcerations, gangrene, and muscle atrophy. And upon auscultating, there might be bruise. Then peripheral pulses may be diminished or absent. Examination of the peripheral pulses is important part of assessing arterial occlusive disease. Unequal pulses between extremity of or the absence of a normal palpable pulse is a sign of peripheral arterial disease. The presence location, and extent of arterial occlusive disease are determined by a careful history of the symptoms and by physical examination. The color and temperature of the extremity are noted, and the pulses palpated. The nails may be thickened and opaque, and the skin may be shiny, atrophic, and dry with sparse hair growth. The assessment includes a comparison of the right and left extremities. Next is the clinical manifestations of patients with peripheral arterial occlusive disease. Intermittent claudication is defined as hurting, cramping, or causing tiredness, fatigue, or weakness that happens with some degree of exertion or activity and is alleviated by rest. Pain is most often felt in the muscle groups distal to the site of stenosis or occlusion. As the illness advances, the patient's ability to walk the same distance as previously may deteriorate, or ambulation may cause increasing discomfort. When the arterial insufficiency becomes severe, the patient has rest pain. This pain is associated with critical ischemia of the distal extremity and is described as persistent aching or boring. It may be so excruciating that it is unrelieved by opioids and can be disabling. Ischemic rest pain is usually worse at night and often wakes the patient. Elevating the extremity or placing it in a horizontal position increases the pain, whereas placing the extremity in a dependent position reduces the pain. Some patients sleep with the affected leg hanging over the side of the bed. Some patients sleep in a reclining chair in an attempt to prevent or relieve the pain.
Now, we are going to discuss the pathophysiology of peripheral arterial occlusive disease, or PAOD. The precipitating and predisposing factors for POAD are the same with atherosclerosis, which are smoking, hypertension, diabetes, hyperlipidemia, obesity, and age older than 60 years old. PAOD could be identified into two groups depending on the cause of the narrowing of the blood vessels. First, we have organic PAOD. These are caused by blockage in the arteries. It is most commonly created by atherosclerosis. Atherosclerosis is a buildup of lipids and fibrous material just under the inner lining of the blood vessel called the tunica intima. When plaque builds up, it narrows the artery, which reduces perfusion to whatever tissue it tends to supply. This buildup usually happens over the course of many years. However, the vessel could be blocked by an embolus, which can happen suddenly if a blood clot from some upstream artery lodges in a peripheral artery. This clot would obviously stop the blood flow from getting to the tissue the blood vessel supplies. With functional PAODs, on the other hand, blood vessels stop blood flow by changing diameter, such as with vasospasms, where the vessel constricts and blood flow is reduced. This type of PAOD is usually short-term and can come and go. When there is less blood that gets into the muscle tissue in the legs, the tissue receives less oxygen and becomes ischemic. Ischemic cells release adenosine, which is a type of signaling molecule, which is thought to affect the nerves in these areas. This is felt as pain, and this pain in the legs are often referred to as claudication. The location of the pain is a clue to which artery is involved. If it's in the hips and the buttocks, think of the lower aorta or iliac. If it's in the thigh, think of the iliac or common femoral artery. For the upper two-thirds of the calf, think of the superficial femoral artery. And for the lower one-third of the calf, it could be the popliteal artery. Finally, for the foot, think of the tibial or peroneal artery. As what mentioned earlier, due to less oxygen being delivered to the tissues, ischemia occurs, which also affects the skin tissues, causing them to die and results to ulceration. Change of colors also happens depending on the elevation of the affected leg. If it is elevated, elevation pallor would occur, which would make the leg appear so pale, since the gravity is working against the blood flow. On the other hand, if the leg is lowered, the patient experiences dependent rubor, making the leg look red. This is because blood is being pulled by the gravity at this time. Complications may also occur when the atherosclerosis increases its size through time. When it almost blocks the blood vessels, it causes rest pain. Rest pain is described as continuous burning or pain in the forefoot and toes when the legs are elevated. This pain is relieved when the limbs are lowered, such as by hanging the feet over the bed or walking around the room, because doing so allows more blood to get down to the foot. When the plaque completely covers the blood vessels, the limb might be at risk of gangrene or death of the tissue, because if deprived of oxygen for long enough, the cells can actually die or necrose. If this happens, the dead tissue would likely have to be removed, and in some cases, the limb would have to be amputated. This time, we are going to discuss the nursing interventions for PAOD. For the first nursing diagnosis, we have ineffective peripheral tissue perfusion related to compromised circulation. The first goal is to increase the blood supply to the extremities. First, instruct the patient to lower the extremities below the level of the heart, because the dependency of the lower extremities helps to enhance the arterial blood supply. Second, patient is also encouraged to have moderate amount of walking or graded extremity exercises if there are no contraindications. Muscular exercise promotes blood flow and development of collateral circulation. For the second goal, we have promotion of vasodilation and prevention of vascular compression. First, patients should be kept warm and avoid cold temperature or areas, because the warmth promotes arterial flow by preventing the effects of chilling, which is vasodilation. And second, the nurse must discourage the patient from the use of any tobacco products, including e-juices that contains nicotine, because nicotine causes vasospasms, which impedes the circulation. And third, counsel in ways to avoid emotional upsets, or do stress management counseling. This is done because emotional stress can cause peripheral vasoconstriction by stimulating the sympathetic nervous system. And for the fourth one, encourage the patient to avoid constrictive clothing and accessories because this may impede circulation and promote venous stasis. For the fifth one, encourage avoidance of crossing the legs because it may cause compression of the vessels, with subsequent impediment circulation resulting to venous stasis. Sixth, administer vasodilator medication and adrenergic blocking agents as prescribed and with appropriate nursing considerations. The vasodilators relax smooth muscles while the adrenergic blocking agents block the response to the sympathetic nervous impulses. The next nursing diagnosis is chronic pain related to impaired ability of peripheral vessels to supply tissue with oxygen. The goal is to relieve the pain. So first you have to do is promote increased circulation through exercise because the enhancement of peripheral circulation increases the oxygen supply to the muscle and decreases the accumulation of metabolites that cause muscle spasms. Also, administer prescribed analgesic agents with appropriate nursing considerations because analgesics helps to reduce the pain and allows the patient to participate in activities and exercises that promote circulation. Then, we have risk for impaired skin integrity related to compromised circulation. The goal is to maintain or attain the integrity of the tissues. First, you have to instruct the patient to, as much as possible, avoid causing any trauma to the extremities since poorly nourished tissues are more susceptible to trauma and bacterial invasion. Also, wound healing may take some time due to poor tissue perfusion. And then second, encourage the patient to wear protective shoes and padding for pressure areas because protective shoes and padding helps to prevent foot injuries and blisters. Then you should also encourage your patient to have meticulous hygiene like bathing using neutral soaps, use of lotion, and carefully trimming the nails because neutral soaps and lotions prevents the skin from drying and cracking. However, avoid applying lotion between toes because maceration of tissues could occur due to increased moisture. Then for the fourth one, caution the patient to avoid scratching or vigorous rubbing because it may lead to skin abrasion and bacterial invasion. And then promote good nutrition to the patient. Instruct the patient to have an adequate intake of both vitamins A and C, protein, and zinc. Or if the patient is overweight or obese, encourage weight reduction because good nutrition promotes healing and prevents tissue breakdown. Then, last but not the least, we also have deficient knowledge regarding self-care activities, which aims to ensure the patient's adherence to self-care program. First, you must include the family and significant others in your health education because adherence to the self-care program is enhanced when the patient receives adequate amount of support from their family and from appropriate self-help groups and agencies. Next, you should also provide written instructions about foot care, leg care, and exercise program because they will serve as a reminder and allows reinforcement of instructions. For the third one, assist to obtain properly fitting clothing, shoes, and stockings because as reasoned earlier, constrictive clothing and accessories impede circulation and promotes venous stasis. And then for the fourth one, refer the patient to self-help groups as indicated. If the patient is a smoker, have them in the smoking cessation clinics. If they are incapable to handle stress or copes up negatively, introduce them to stress management counseling, and if the patient is overweight or obese, they may submit themselves to weight management and exercise programs. By doing this, the risk factors may be reduced, thus reducing the symptoms or slow the progress of the disease. And that is all for the PAOD.
Hi, I'm Mary Esel Vicentes, and this is Upper Extremity Arterial Occlusive Disease. So this is our table of contents. Number 1, definition. Number 2, signs and symptoms. Number 3, pathophysiology. Number 4, laboratories or diagnostic exams. Number 5, treatment. Number 6, we have here nursing management. Number 7, the nursing diagnosis. Number 8 is the medications. So, what is upper extremity arterial disease? Occlusive arterial disease. So, upper extremity arterial disease is much less common than the lower extremity involvement and typically presents as arm claudication, Raynaud's syndrome, rest pain, ischemic ulcerations, or gangrene, and cause less severe symptoms because the collateral circulation is significantly better in the arms. So, occlusive arterial disease is a blockage or narrowing of of an artery in the rarely rarely in the arms, usually due to atherosclerosis and resulting in decreased blood flow.
And now we are going to talk about the pathophysiology. So in here is a concept map of the pathophysiology of the upper extremity arterial occlusive disease. And it all leads to the occlusion of the upper distal vessels. So the predisposing factors of this disease is the high cholesterol levels in the blood, high blood pressure, and a family history of heart or any vascular diseases. Its precipitating factors are smoking or any history of it, obesity, and atrial fibrillation. Its etiology are placed in the middle, which are the arteritis, atherosclerosis, fibromuscular dysplasia, and Raynaud's disease. So in AFMI or CHF, it develops an arterial embolus in the chambers of the heart, wherein the thrombi detaches, then carries from the left side of the heart to the arterial system. And then the thrombi lodges and obstructs on an artery, which then leads to the blockage that progresses to the upper distal and proximal to the site of the obstruction. And in here, the embolus may break apart, which leads to the occlusion of the upper distal vessels and leading to the upper extremity arterial occlusive disease. And another factor that this etiology affects is there is a deficiency of vasodilating substances, wherein vasospasm occurs, leading to the increased clot formation and increased production of platelet thrombocyte, which causes the platelets to aggregate, and then leading it again to the occlusion of the upper distal vessels, which causes the disease. And another is when an atherosclerosis plaque ruptures, the platelet-rich thrombus will then develop, and then this will damage the arterial wall, generally a result to the atherosclerosis, wherein there will be a blood flow cessation and then occluding the upper distal vessels, leading to the upper extremity arterial occlusive disease. It is due to the atherosclerosis mostly situated at the level of the brachiocephalic trunk and the subclavian and axillary arteries. And here are the symptoms of the disease, which is pain, pallor, absence of pulse, coldness of skin, paresthesia, and paralysis. So this is the concept map of the pathophysiology of the disease. Moving on, we have our nursing diagnosis. In here, we can present three nursing diagnoses. First is the acute pain related to decreased upper arterial blood flow. Second is ineffective peripheral tissue perfusion related to impaired arterial circulation. And lastly is activity intolerance related to imbalance on oxygen supply and demand. So we are going to discuss our main objectives of management to that nursing diagnosis. So first, our main objective is to demonstrate the relief of pain. The patient will demonstrate a relief of pain as evidenced by stable vital signs, absence of muscle tension, and restlessness. Second is the patient will maintain maximum tissue perfusion to vital organs as evidenced by warm and dry skin, present and strong peripheral pulses, vitals within normal range, balanced input and output, and alert level of consciousness. And lastly is
the patient will exhibit a growing tolerance to activity.
Now we will proceed to discuss on the laboratories and diagnostic exams, and these tests will support or confirm or refute the diagnosis that was suspected on the basis of other information sources. Okay, so now the laboratory and diagnostic exams of this disease will contain laboratory tests and also non-invasive vascular laboratory studies. So let's proceed. So in the laboratory test, number one is chest X-ray. So this will identify enlarged heart or heart failure, and then also prominent lung markings, atelectasis, and then infiltrates or effusion associated with CHF, and also bony structure anomalies causing vascular compression. Next is electrocardiogram or ECG. So this will assess for arrhythmia or myocardial infarction, and if arrhythmia is new, we will need to evaluate for possible myocardial infarction. So by using this, we can localize the myocardial infarction and determine the occluded coronary artery. Next is the echocardiogram. This will assess the valve disease or cardiac enlargement and chamber function. This also helps your doctor to determine whether all parts of the heart wall are contributing normally to the heart pumping activity. Next, transesophageal echocardiography. So this is performed in patients with peripheral embolus suspected of originating from a cardiac source. TEE can be used to assess plaque in the ascending aorta as a source of the emboli or determine the presence of a right-to-left shunt through which paradoxical emboli might travel. Next, number 5 is complete blood cell count. This will This test will determine platelet count, sedimentation rate, anti-nuclear antibody or ANA, then rheumatoid factor for possible inflammatory or infectious origin, and disease-directed laboratories as appropriate. Next is the preoperative laboratories for acute ischemia or trauma. So this will include the following tests: the CBC, electrolytes, type and cross-match, consider troponin, creatine kinase, and urine myoglobin if the patient has been immobile for a prolonged period of time. Next, we have the hypercoagulable workup. So these tests will include CBC with platelet count, fibrinogen, prothrombin level, partial thromboplastin level, protein C deficiency, protein S deficiency, factor V Leiden mutation, prothrombin gene mutation, then antithrombin third deficiency, and antiphospholipid antibody, anticardiolipin antibody, and homocysteine. So this test is used to determine if the patient has inherited hypercoagulable states. Okay, so now let us proceed to the non-invasive vascular laboratory studies. In here is the segmental arterial pressures. So in this examination, the pressures are taken in the brachial, radial, ulnar, and palmar arc vessels. So the pressures in one arm are compared to the pressures in the opposite arm. So an abnormally large pressure gradient is greater than 20 millimercury. So between any two segments, this will indicate the disease. Number 2 is finger pressures. So this procedure, we will have finger cuff used with a Doppler probe to measure the systolic pressure. And then the absolute finger pressure is less than 70 millimercury is considered abnormal. Okay, so next, we have the Doppler flow studies. Um, the subclavian artery, brachial, radial, ulnar, and digital arteries may be examined and analog waveforms recorded at each site. So the waveforms will change from triphasic to blunted or monophasic at the level of obstruction. So this may be performed Allen test while obtaining waveforms to document pulmar arc status and vessel dominance or evidence of thoracic outlet obstruction respectively. And then the Doppler scanning will aid in diagnosis of the more proximal vessels. And the last non-invasive examination, we have the duplex and color flow scanning. So the color flow scanning facilitates more accurate identification and location of vessels as well as the visualization of aneurysms, pseudoaneurysms, or arteriovenous malformations. In the color, arterial flow is normally red and the venous flow is blue. So if there is absence of color in an artery that is clearly visualized on B-mode scanning, it is diagnostic of occlusion. And a color shift from red to white, this identifies stenotic sites with turbulent flow. And the hemodialysis graph flow with Doppler velocity recordings from the proximal anastomosis to the distal, and measurements of vein diameter, and also assessment of the inflow and outflow vessels, and allows anatomic visualization. Now for the medications of the upper extremity arterial occlusive disease, we have medical treatment options depending on circumstance. This includes the following: long-term warfarin, aspirin or clopidogrel, nifedipine, prazosin, and hydralazine, and also prednisone, methotrexate, or cyclophosphamide. So that would be all for the report of the upper extremity arterial occlusive disease, and let's proceed to the next reporters. Thank you.
For the treatment, we have here first is risk factor control, and best medial therapy are recommended in all patients with symptomatic upper extremity artery disease to reduce cardiovascular risk. Next is if a short focal lesion is identified in upper extremity artery, upper cutaneous transluminal angioplasty or PTA with possible stent or stent graft placement may be performed. Next is if the lesions involve the subclavian artery with documented siphoning of blood flow from the intracranial circulation, and interventional radiologic endovascular procedure is not possible, surgical bypass may be performed wherein it redirects blood around a section of a blocked or partially blocked artery in your heart. Next is revascularization. It's a procedure to restore blood flow to the heart or another organ after the arteries have been plugged with cholesterol or plaque. So indicative in symptomatic patients with transient ischemic attack or stroke, coronary subclavian steal syndrome, or ipsilateral hemodialysis access dysfunction or impaired quality of life. Next is open surgery. Surgical subclavian carotid transposition is safe with good long-term patency surgery. Carotid subclavian bypass surgery with prosthetic graft showed long-term benefit with low operative mortality and morbidity rates, especially in patients with extensive disease or reocclusion after stenting. Other options like extrathoracic extra-anatomic bypass or from axillo-axillary, carotid axillary, or carotid bypass. The transthoracic approach is an option in patients with multi-vessel disease involving the aortic arc and several supra-aortic vessels. Next is the nursing management, our number 6. So for our nursing management, we have here the quality and safety nursing alert. So before the surgery and for 24 hours after surgery, the patient's arm is kept at heart level and protected from cold, venipunctures, or arterial sticks tape, and constrictive dressings. So, disappearance of a pulse or Doppler flow that had been present may indicate an acute occlusion of the vessel, and the primary provider is notified immediately. After surgery or endovascular procedure, the arm is kept at heart level or elevated, with the fingers at the highest level. Pulses are monitored with Doppler assessment of the arterial flow every hour for 2 hours, and then every shift. So, blood pressure obtained by the stethoscope and Doppler is also assessed every hour for 4 hours, and then every shift. Motor and sensory function, warmth, color, and capillary fill are monitored with each arterial flow pulse assessment. Thank you for listening.
Next, we have Thromboangiitis Obliterans or Buerger's disease. So, first, let's define and describe Thromboangiitis Obliterans. So, it is a non-atherosclerotic segmental inflammatory disease that most commonly affects the small to medium-sized arteries and veins of the extremities, both upper and lower. So, since this is a disease or inflammation disease, the blood vessels can become inflamed, swell, and can be blocked with blood clots. So the inflammation and irritation contributes to the development of vasospasms, and these vasospasms can lead to an obstruction in the blood flow. So the disease is usually the result of an occlusion of the vessels by thrombus formation. Thromboangiitis obliterans is also called as Buerger's disease, named after Leo Buerger, who published a detailed description of the pathologic findings of amputated limbs in patients with the disease in 1908. So heavy cigarette and tobacco smoking is a major contributing factor of the disease. So some studies indicate that an autoimmune response to tobacco products as possible cause. Now, who among the population is most affected? So the prevalence is that the disorder is more prevalent in young men from ages 25 and 40. So between 25 and 40 years old in young men. So next, here is a picture of thromboangiitis obliterans in the upper extremity or the hand. So we can see here that the blood vessel is obstructed, and since this blood vessel is obstructed, there is not enough blood coming through that vessel and to the cells of the finger. So there is no more oxygen coming to that part, hence the death of the cells and tissues. Because since the blood flow is constricted, there is no longer oxygen supplication for that area of the extremity. Next, we have the three phases of the Buerger's disease, namely the acute phase, subacute phase, and the chronic phase. First, let's discuss the acute phase. So it is comprised of an occlusive, highly cellular inflammatory thrombi. So the external lamina of the vessels of the distal extremities are usually affected first by the inflammatory thrombi. And then the thrombi cause occlusion while the leukocytes and giant cells infiltrate the vessel margins. And the superficial veins in particular may show evidence of thrombophlebitis. And this thrombophlebitis is usually a characteristic and diagnostic of the acute phase. Next, we have the subacute phase. So it is characterized by a progression or progressive organization of the thrombus with the vessel. So there is a progression of the thrombus taking place within the vessel. Next, we have the chronic phase. So in this phase, inflammation is no longer present. However, there is a continued presence of organized thrombi with vascular fibrosis this time. So that is your phases of the Buerger's disease. For the assessment, so when dealing with patients having arterial occlusive disorders, monitoring the peripheral circulation is most important. Careful assessment of pulses, capillary refill, temperature, color, and presence of edema helps identify patients at risk for complications. And if there is an absence of pulses, it should be reported immediately. And if the skin is shiny and hairless, it indicates that there is a diminished blood flow to the extremity. And if there are any skin lesions and ulcerations, it should be noted as well during assessment. Now let's move on to the signs and symptoms of thromboangiitis obliterans. So it includes color changes on the skin, which can become bluish or purplish due to the decreased blood flow coming to that area. Next, we have intermittent claudication, meaning there is pain on the extremities and it is intermittent. Next, numbness. Rest pain, there is pain even at rest. Decreased sensation, cool extremities, cyanotic, and Raynaud's phenomenon, meaning it is a problem that causes decreased oxygen to the fingers. So I will just show you pictures later of these signs and symptoms. Next, we have ulceration and the digital gangrene. So here are the pictures of the signs and symptoms. We have color changes in the skin. As you can see, it is bluish in color at the fingertips because there is an occlusion of a blood vessel, and since the blood vessel is occluded, the blood cannot flow through and there is not enough oxygen coming to the cells and tissues in this area, hence the decreased oxygen supplication. Next, we have intermittent claudication. So there is pain at the lower extremities. We have cool extremities. A person with thromboangiitis obliterans can feel coldness on their extremities. We have digital gangrene. As you can see, the fingertips are almost damaged and it is black in color. Okay, this is digital gangrene. Rest pain. Raynaud's phenomenon. This is what Raynaud's phenomenon looks like. So the fingertips lacks oxygen, hence the color. And we have ulceration. Okay, so there is a skin ulceration. And these are the signs and symptoms that you can see when a patient has a thromboangiitis obliterans or Buerger's disease. Next, we have the laboratories and diagnostic tests. So first, we have blood tests. So blood tests can be done to look for certain substances that can rule out other conditions that may cause similar signs and symptoms. For instance, blood tests can help rule out autoimmune diseases such as scleroderma, blood clotting problems or disorders, and diabetes. Next, the Allen's test. So this is to check blood flow through the arteries carrying blood to the hands. Angiogram is to help see the condition of the arteries. Ultrasound, findings on an ultrasound suggestive of Buerger's disease include corkscrew collaterals. Next, we have echocardiography. This may be helpful in detecting the source of thromboembolism. Then, computed tomography and magnetic resonance may be performed to exclude a proximal arterial source of embolism and to define the anatomy and extent of the disease. When ruling out acute phase reactants that indicate an active inflammatory process, we have the ESR or erythrocyte sedimentation rate and the C-reactive protein or CRP. To rule out hypercoagulability, we have complete blood count and liver function test. And lastly, for immunologic panel to rule out autoimmune diseases, we have autonuclear antibody or ANA, rheumatoid factor, anti-centromere antibody, and SCL70.
Hi, I'm Jessa Compencio. I'm going to discuss about the pathophysiology of thromboangiitis obliterans and also its managements and the nursing diagnosis. So, the pathophysiology of thromboangiitis obliterans, or known as Buerger's disease, it has a precipitating factor. So a precipitating factor is a factor that triggers the onset of the current disease. So the first one is the gender, primarily male client. So the second one is age between 20 years old to 60 years old, and a history of hypertension and hyperlipidemia. And also, the precipitating factors is genetics, and lastly, the race in which most Southeast Asian are affected. For the predisposing factors of this disease is that a predisposing factor is a factors that put the patient at risk in developing this disease. So the first one is the lifestyle, in which cigarette smoking, chewing of tobacco, and sedentary lifestyle. And the second one is the environment, in which the exposure of cold and stressful environment. So the main cause of this disease is cigarette smoking. So in cigarette smoking, there is a production of nicotine, carbon monoxide, and carbon dioxide. So nicotine can cause vasoconstriction of the arteries, while the carbon monoxide can cause destruction of the lining of the blood vessel. And also, this carbon dioxide can cause decreased oxygen transport of the tissues. These three chemicals can lead to triggering autoimmune response, in which it can lead to tissue ischemia. So a tissue ischemia is there is a deficiency in the blood tissue. So it can lead to vasoconstriction and vasodilation of the blood vessel. So this tissue ischemia can lead to anaerobic metabolism, in which there is an ATP production without oxygen, and this can lead to lactic acid formation and also intermittent claudication. So intermittent claudication can cause pain on the patient calf, thigh, and buttocks. So this tissue ischemia can lead to cyanosis, in which this anaerobic metabolism, lactic acid formation, and intermittent claudication, and this cyanosis can lead to tissue hypoxia. So a tissue hypoxia is there is a starve in oxygen on the tissues. So this can lead to rest pain, and also the tropic changes, in which there is a dryness, scaling of skin, loss of hair, thickened and ringed toenails of the client. So these two can lead to tissue necrosis, in which tissue necrosis is there is a death on the tissues of the body. So tissue necrosis can lead to numbness, pallor, in which there is a pale on the skin, and coldness. So this can lead to tissue ulceration. Tissue ulceration, which can lead to gangrene, in which patient, if having gangrene, are risk for having amputation. So that is the physiology of the Thromboangiitis Obliterans, or the Borders disease. So the pathological features of this disease is that it is categorized in three phases, including acute, subacute, and chronic. So the characteristic of acute phase is there is a hypercellular and inflammatory thrombus with minimal inflammation in the vascular wall of the affected vessel. So in this phase, there is a polymorphonuclear leukocytes are predominant cells at the site of the inflammation, in which there is a form of microabscess within the thrombus. However, the second phase is the subacute phase. There is a microabscess around or surrounded by a granuloma, which may lead to the organization and recanalization of the thrombus. So finally, for the last phase, which is the chronic phase, inflammation is no longer present, and organized thrombus and vascular fibrosis remain. So fibrosis is observed in the end stage of this phase. The main objectives of the management are: the first one is to improve the circulation to the extremities, the second one is to prevent the progression of the disease, and the last one is to protect the extremities from trauma. For the medical management are: the first one is treatment of ulceration and gangrene is directed toward minimizing infection and conservative debridement of necrotic tissue. So the tobacco use is highly detrimental and patients are strongly advised to stop using tobacco completely. So vasodilators are rarely prescribed because these medications can bleed away from partially occluded vessels, making the situation getting worse. So the prostaglandins such as limpaprost are vasodilators in which it is used to relieve pain from patients. So a regional sympathetic block such as ganglionectomy may be useful in some instances to produce vasodilation and increase the blood flow for the tissue. So debridement is done for the necrotic ulcers. So in chronic cases, lumbar sympathectomy is done to reduce the vasoconstriction and increases the blood flow of the limb. So above knee and below knee amputation is done rarely for the severe case disease of the patient. So anti-inflammatory drugs such as corticosteroids are used for inflammation and pain relief. So bypass can sometimes be useful in the rare cases. So a nerve surgery is a surgery to cut the nerves to the affected area. It is a surgical sympathectomy to control pain and increase the blood flow through the procedure. So it is very controversial and a long-term process. Growing new blood vessels, a therapeutic angiogenesis, it is a medication that used to stimulate the growth of a new blood vessels. So for bosentan clear, this medication has been approved for treating high blood pressure in the lungs since these diseases can cause the vasoconstriction of the blood vessels. So there is a possibility for hypertension. So this drug improves the blood flow of the patient. So blood vessel procedure, it is a thin catheter threaded into the blood vessel. It might open the blood vessels and restore blood flow. And this procedure is called endovascular therapy. For the nursing management, first is if amputation is performed, elevating the stump for the first 24 hours to promote venous return and minimize edema, and the incision is monitored for the signs of hematoma. So the patient may experience grief, fear, and anxiety related to the loss of the limb. So the patient is encouraged to discuss his or her feelings. Also, spiritual advisors and other healthcare team members are consulted as appropriate. For the recovery and rehabilitation require consultation of the healthcare providers, such as the physicians, the dietitians, the prosthetics, the physical and occupational therapists, as well as the nurses. So the patient is assisted in developing plan to stop the tobacco and marijuana use exposure. The patient may need to encourage to make lifestyle changes necessary with a chronic disease, so including the modification of his or her diet, activity, and hygiene, specifically for the skin and oral care. So the nurse must determine whether the patient has network for family and friends to assess with his or her activities in his or her daily livings. So the nurses ensures the patient that the knowledge and ability to assess for any postoperative complications such as infection and decreased blood flow. And lastly, for the nursing diagnosis. So I composed 3 nursing diagnoses, which is the first one is ineffective peripheral tissue perfusion related to impaired circulation. So the second one is pain related to diminished oxygen flow to the affected extremity. So the last one is fear and anxiety related to actual or potential serious complications. Thank you for listening.
Now, let's talk about aortoiliac disease. Now, for the disease overview, aortoiliac disease or the aortoiliac occlusive disease is the narrowing or blockage of an iliac artery. So, the aorta, the largest blood vessel in the body, runs through the center of your chest and abdomen, carrying oxygen-rich blood from your heart to the rest of your body. So, the iliac arteries branch off your aorta and carry blood to your legs. So, aortoiliac disease, a type of peripheral artery disease, specifically affecting the lower aorta. So, in the same manner as peripheral artery disease, the aortoiliac disease is typically caused by atherosclerosis. As shown in the picture above, you can see the normal artery and the atherosclerotic artery. So, you can see the difference between the two. It results from fatty deposits called plaque building up in the arteries and causing them to become narrow and block. This build-up or the atherosclerosis not only slows down blood flow, it also makes the arteries vulnerable to injury and clot formation. So aortoiliac disease can cause the following problems: prevent blood from reaching parts of the buttocks, groin, legs, and feet. Cause disorders of the pelvic organs, legs, kidneys, or intestines such as renal artery disease and mesenteric artery disease. Another is it results in an abdominal aortic aneurysm. Now let's go for the risk factors. So because aortoiliac disease is mainly caused by atherosclerosis, the risk factors are the same. So a leading risk factor of aortoiliac occlusive disease is hypertension or the high blood pressure, which can damage artery walls, making you prone to narrowing or blockages. So high blood pressure can also increase the risk of atherosclerosis, the main cause of aortoiliac occlusive disease. So other risk factors include smoking, obesity, diabetes, and hyperlipidemia, a condition caused by unhealthy levels of fats in the blood. People who are sedentary are at increased for the conditions that lead to aortoiliac occlusive disease. So for the clinical manifestations, early in aortoiliac disease, you may experience pain, cramping, and fatigue in your lower body when you walk or exercise. So as the disease worsens, you may have more severe symptoms including erectile or sexual dysfunction as a result of decreased blood flow, severe pain, coldness or numbness, ulcers or sores on your toes, heels or lower legs, weakened muscles, heart failure, myocardial infarction, gangrene or the tissue death, and amputation are also increased in unmanaged aortoiliac occlusive disease.
Let's discuss about the pathophysiology of aortoiliac disease. So for a recap, aortoiliac disease is a disease in which obstructing plaques occur in the infrarenal aorta and iliac arteries, leading in partial or total vascular occlusion. The atherosclerotic plaques may induce symptoms either by obstructing blood flow or by breaking apart or embolizing atherosclerotic or thrombotic debris to more distal blood vessels. If the plaques are large enough to block on the arterial lumen, reduction of blood flow to the extremities occur. The most common cause of this condition is the atherosclerosis, in which there is a build-up of fats, cholesterol, and other substances in and on the artery. Other known causes are the hypercholesterolemia and tobacco usage. The uncommon cause of this condition is the Takayasu disease, in which it is a nonspecific arteritis that can cause obstruction of the abdominal aorta and its branches. There are risk and contributing factors that can aggravate the disease to develop. These are hypertension, obesity, diabetes mellitus, elevated homocysteine levels, hyperlipidemia, and smoking. Because of the atherosclerosis, there is a waxy substance that contains fat, cholesterol, and calcium called plaque that is building up in the arteries. It then narrows or stiffens the iliac arteries. It will lead to a reduced oxygen blood flow to the lower extremities of the body. Accumulation of lipids start in the smooth muscle cells, and then macrophages will occur as an inflammatory response to endothelial injury, and then plaque begins to form in the arterial lumen. Platelet aggregation then is stimulated. Platelets will then bind to fibrin through activation of the glycoprotein receptor on the platelets, and a fresh blood clot will form in the area of the plaque breakdown. These unstable plaques are susceptible to atheromatous embolization or propagation of clot that eventually can occlude the arterial lumen. If the plaque will increase its size and will occupy at least 50% of the arterial lumen, the velocity of the blood flow through the stenosis can basically increase. It will become extensive to the aortoiliac segment. Most men with aortoiliac disease present with impotence and sexual dysfunction secondary to reduced penile arterial flow. When the aortoiliac segment is obstructed, the person may manifest these symptoms: pain, cramping, and fatigue in the thighs, buttocks, or legs. It can only occur during exercise but is absent if the person is sedentary. The oxygen requirements of the lower extremity at rest is low enough that even with a moderate proximal stenosis, no increase in blood flow velocity occurs. During exercise, however, the oxygen that occurs in ischemic muscle cannot be relieved because of the proximal obstruction of the blood flow. Thus, this results in claudication symptoms. As it worsens, more severe symptoms will appear, such as extreme pain, coldness, and numbness in the legs, buttocks, and thighs, even when the person is at rest. This is because of the ischemia, a condition in which there is a decrease in the blood flow in the supply of the blood and oxygen to the tissue. Because of ischemia, the person will have open sores or ulcers, tissue death or gangrene, muscle atrophy or shrinkage in one or both feet, and then numbness, coldness, and extreme pain to the legs, thighs, and buttocks. This will lead to limb loss without a proper treatment. The prognosis of this condition is poor without the proper interventions. That's all for the pathophysiology of aortoiliac disease.
Hi everyone, good day. I am Billy Davis. I am going to discuss the diagnostics and laboratory tests for the aortoiliac disease or the aortoiliac occlusive disease, as well as its management. To diagnose aortoiliac occlusive disease, doctors examines the legs and takes a medical history to determine the risk factors. The doctor takes the blood pressure and pulse in the thigh, calf, foot. This is to determine if the blockage is in the aorta or the iliac or femoral arteries, which causes the inadequate blood flow. Doctors may order one or more of the other tests to look for the signs of an arterial blockage in the pelvis or the leg. So first we have the arterial Doppler ultrasound. A Doppler ultrasound uses sound waves to produce color images that shows the flow of blood through the arteries of the pelvis and the legs. It allows doctors to detect and evaluate blockage caused by the plaque buildup. During the ultrasound, a handheld instrument called transducer is pressed against the skin to determine sound waves. It produces images of the blood vessels in the pelvis and legs in a computer monitor. So these tests may take about 30 to 60 minutes. Next is the ankle brachial index. An ankle brachial index allows the doctors to determine the severity of blockage in the arteries in the lower part of the body. In this test, the doctor measures blood pressure in the ankle and in the arm and compares the result. A low ankle brachial index can indicate a blockage. These tests can also help determine the risk of heart attack and stroke. Next, we have the CT scans. In a CT scan, X-rays and computer create three-dimensional cross-sectional images of the body. The test helps the doctors determine if the patient have any narrowing or blockage in the pelvic or leg arteries. So before the scan, the patient may be given a intravenous dose of a contrast agent, which is a liquid dye that travels through the blood vessels to enhance the image. So these tests may take about 10 to 15 minutes to complete. Then we have the angiogram. Angiogram uses X-rays to detect blockage in the arteries. So during this test, the doctor uses a needle to make a small puncture near groin and inserts a catheter, which is guided into an iliac artery. The doctor injects a contrast dye into the catheter to highlight a narrowed or blocked arteries. Sometimes this test is done at the same time as a procedure called balloon angioplasty and stenting to clear and widen blocked and narrow arteries. It is performed using local anesthesia. Angioplasty and stenting can take less than an hour or up to several hours depending on the severity of the condition. And during the angiogram, the patient may feel pressure when the catheter is inserted and a warm sensation when the contrast material is injected. Afterwards, the doctor may suggest avoiding certain activities, such as lifting heavy objects and exercising strenuously. This is to avoid preventing bleeding in the area where the catheter was inserted. Medical management. First, we have the lifestyle changes. Doctors may recommend several lifestyle changes in managing the aortoiliac disease. So, in the lifestyle habits, smoking, being sedentary, and eating unhealthy foods can lead to high blood pressure, obesity, diabetes, which is all risk factor for aortoiliac occlusive disease. These habits can also lead to hyperlipidemia, which is a buildup of fats in the blood vessel that can stress the heart and cause a plaque to build up in the arteries and the veins. Then the atherosclerosis, which is a buildup of plaque in the leading cause of the aortoiliac occlusive disease and other peripheral artery disease. Doctors may recommend several lifestyle changes such as improving the diet and exercising regularly to improve the health on the arteries and of course to prevent symptoms from getting worse. Lower blood pressure. High blood pressure or hypertension stresses the heart and the blood vessels. Over time, it can lead to organ and tissue damage, heart disease, heart attack, or stroke. Because high blood pressure can be a sign of plaque buildup in the arteries, doctors monitor the blood pressure and other symptoms, such as pain in the legs, which can indicate of having aortoiliac occlusive disease. If the patients have hypertension, doctors recommend to have a blood pressure monitored regularly. The patient may be able to lower the blood pressure by adhering to a diet that includes fruits, vegetables, and whole grains and reduce the salt intake. Doctors may also suggest exercising regularly, decreasing alcohol consumption, and quitting smoking to reduce the blood pressure. And the patient also need to quit smoking. One of the best ways to prevent or stop the progression of aortoiliac disease is to quit smoking. The chemicals in a cigarette harms the blood cells and blood vessels and increase the risk of the plaque buildup in the arteries. When combined with high blood pressure, obesity, unhealthy cholesterol levels, or uncontrolled diabetes, smoking puts the patient at an even higher risk of developing aortoiliac disease. Then eat healthfully. Elevated levels of cholesterol in the blood can cause blockage in the arteries. Now, there are two types of cholesterol, which is the high density lipoprotein and the low density lipoprotein or the LDL. HDL is also known as the good cholesterol, which helps to remove unhealthy cholesterol from the body. Now, the LDL is the bad cholesterol, which attach to the artery walls, possibly blocking them. Too much bad cholesterol or not enough good cholesterol in the blood can increase the risk of developing a buildup of plaque in the blood vessels. Doctors suggest to consume more fruits and vegetables as well as lean proteins to keep cholesterol levels in check. They may also recommend to limit or avoid fried foods, sugary desserts, heavy cream, and fatty cuts of meat. Patient must also exercise regularly. A regular exercise lowers bad cholesterol and boosts good cholesterol, which reduces the plaque buildup in the arteries and improves the circulation. Exercise also elevates the symptoms of diabetes and high blood pressure as well as stress, which can contribute to hypertension. The patient must also manage the stress. Stress affects the blood pressure by making the heart work harder. Too much daily stress can have a long-term and often negative effects on the health. If the patient has been diagnosed with aortoiliac disease, the doctor may advise to sleep 8 hours a night, engage in yoga and other exercise, meditate, or if possible, work fewer hours. Then in control of the hyperlipidemia. People with hyperlipidemia, which is a condition in which fats build up in the blood, are at higher risk of developing atherosclerosis. So managing hyperlipidemia is important in preventing aortoiliac disease. Doctors may recommend lifestyle changes, including quitting smoking, exercising regularly, and increasing the fiber intake, which can also help the body absorb cholesterol from the intestine. The doctor may also prescribe medications such as statins, which lowers the level of the cholesterol in the body. Then control the diabetes. People with uncontrolled diabetes are prone to developing plaque in the arteries of the legs. This can lead to inadequate blood flow to the legs and feet, which can in turn hinder the healing of scratches, cracks, or abrasions on the skin. The feet can become enlarged and infected, leading to gangrene or tissue death. Now, managing diabetes is essential preventing aortoiliac diseases. Specialists teach self-care skills to prevent or to help the patient manage the condition. This may include instruction in home glucose monitoring and insulin injections. The next slides will be about the medications indicated for the aortoiliac disease. Medications are often prescribed along with other treatments, such as lifestyle changes and minimally invasive procedures. Doctors may prescribe medications to manage blood clots, high blood pressure, diabetes, and cholesterol levels, all of which can contribute to the aortoiliac disease. So first we have the medications for managing blood clots. Doctors may prescribe anticoagulant or antiplatelet medication to reduce blood clotting and increase blood flow. Anticoagulants are blood thinners which slows the formation of blood clots. They may reduce risk of the aortoiliac disease as well as help lower the blood pressure. But side effects include bleeding and bruising. Now the antiplatelets are a group of medication that prevents platelets from forming a blood clot. Then managing the hypertension. Hypertension or high blood pressure can be a warning sign of having aortoiliac disease. It indicates that the heart is working hard to pump blood through narrowed or blocked arteries and veins. Then we have the diuretics. Doctors often first prescribe a thiazide medication, which is a class of diuretic, to manage high blood pressure. A diuretic causes sodium and water to be eliminated from the body, resulting in an increase of urine production. This reduces the amount of fluid in the blood vessels, creating less work for the heart. Then we have the angiotensin converting enzyme inhibitors. Angiotensin converting enzyme, or the ACE inhibitors, widen or dilate blood vessels to improve the blood flow. They work by blocking angiotensin and enzymes that narrows the blood vessels. Side effects can include elevated potassium levels in the blood, dizziness, headache, and drowsiness. Then the angiotensin 2 receptor blockers. Like the ACE inhibitors, angiotensin 2 receptor blockers prevent blood vessels from narrowing by causing the nearby muscles to contract. They may be prescribed to people who cannot tolerate to ACE inhibitors. Side effects for some people includes elevated potassium levels in the blood and a metallic taste in the mouth and a rash. Then the calcium channel blockers. Calcium channel blockers relax blood vessels, making more room to blood to flow. These medications do this by slowing the absorption of calcium in the heart muscles and in blood vessel walls. Side effects can include low blood pressure, constipation, and swelling caused by the buildup of the fluid in the legs and the feet. Beta blockers. Beta blockers relax and widen blood vessels by blocking the hormone adrenaline, allowing the heart to beat more slowly. For best results, beta blockers are typically prescribed with the other blood pressure medications. Then the lowering cholesterol medications. Elevated levels of cholesterol can lead to a full or partial blockage of the artery, a leading cause of the aortoiliac disease. If the patient have unhealthy cholesterol levels, physicians may prescribe medications to treat conditions. One of the type of medication is called the statins, which blocks a substance that the liver uses to make cholesterol. Statins helps the body to reabsorb cholesterol from the plaque buildup inside the arteries, which may reverse aortoiliac disease. Another type of medication is called the cholesterol absorption inhibitors, which limits the body's ability to absorb cholesterol from food, lowering cholesterol levels. And controlling diabetes. Patients with uncontrolled diabetes may develop blockage in the arteries and the lower leg. Treatment depends on the type of the diabetes a person has. People with type 1 diabetes, for instance, must take insulin, which is given by injection because their body doesn't produce the substance naturally. Some people with type 2 diabetes, in which the body doesn't use insulin properly, can be managed the condition by eating well and exercising regularly. Others with type 2 diabetes may need to take medications in addition to making lifestyle changes and to maintain healthy blood pressure level. These medications can be taken by mouth or injected. Then we have the minimally invasive procedures. When lifestyle changes and medications don't relieve symptoms of the aortoiliac occlusive disease, vascular specialists may perform minimally invasive procedures to improve blood flow to the lower body. These techniques provide alternatives to those who are not good candidates for surgery because the medical conditions that makes it dangerous. Doctors may perform one or more of these procedures to widen the iliac artery. So first we have the atherectomy. If the patient have a severe artery blockage, doctors may recommend the atherectomy, which is a procedure in which the doctor removes the plaque, a waxy substance composed of fat, cholesterol, and calcium, by shaving, cutting, or vaporizing it. During the atherectomy, the surgeon inserts a catheter, which is a thin hollow tube, above the femoral artery in the groin. Then he or she guides the catheter to the blocked area of the artery and removes the plaque using tool attached to the tip. The surgeon may then perform a balloon angioplasty and stenting, which helps to prevent future blockage. An atherectomy is performed either in the hospital or the doctor's office, using a local anesthesia and a mild sedative. Most people can go home the day of the procedure. As mentioned, balloon angioplasty and stenting often accompanies an atherectomy. During the procedure, the surgeon makes a puncture with a needle in the groin and advances a long catheter through the femoral artery to the blockage in the iliac artery. A tiny balloon at the end of the catheter is inflated, pushing plaque to the sides of the artery walls, making room for the blood to flow. Then the doctor inserts a metal mesh tube called the stent into the artery through the catheter and opens it. This stent prevents the iliac artery from narrowing again. When the procedure is done, the surgeon removes the balloon and catheter but leaves the stent in place permanently. The procedure, which is performed using local anesthesia, lasts about 30 to 90 minutes depending on the severity of the blockage. It can be done in the doctor's office or in the hospital with or without an overnight stay, depending on the overall health. Most likely, patient can resume the usual activities within 2 days. When lifestyle changes, medications, or minimally invasive procedures don't prevent or relieve the symptoms of the aortoiliac occlusive disease, doctors may recommend surgery to bypass pelvic artery blockage and prevent new ones from developing. First, we have the leg bypass surgery. Doctor may perform a leg bypass surgery if the patient have a large arterial blockage and severe symptoms. This surgery may be performed if a less invasive procedure doesn't improve the symptoms or if a minimally invasive procedure isn't possible, such as when the blockage is very long or crosses over a joint such as the hip or the knee. Doctors may recommend this surgery if the patient have intermittent claudication or pain when walking. It's most commonly used for people with gangrene or skin ulcers. The patient may also need this procedure when there is a pulmonary embolism, which is a blood clot in the leg that breaks loose and travels through the bloodstream to an artery in the lungs, causing a potentially life-threatening blockage. Performed using general or local anesthesia, leg bypass surgery allows the surgeon to create a new route for blood to travel around the blocked artery. This restores the blood flow to the leg and prevents the need for amputation, which may be necessary when a body part is affected by gangrene. So during the leg bypass, the surgeon makes an incision in the leg, then selects and removes a healthy vein to serve as a bypass graft for the blocked artery. Next, the surgeon clamps the vein and makes an incision near the blocked portion of the artery. He or she opens the artery and connects one end of the vein graft with permanent stitches. Then the doctor clamps and opens the artery above the blockage and connects the other end of the graft. After the procedure, the doctor ensures the bypass is functioning properly by using a Doppler ultrasound to evaluate the blood flow in the artery. The procedure typically requires a hospital stay of 3 to 10 days. Stitches are removed from the incisions 1 to 2 weeks after the surgery. During this time, the surgeon may prescribe an antiplatelet medication to prevent blood clots from forming around the bypass site. Then the common femoral artery endarterectomy. If the blockage appears in the femoral artery, which extends from the iliac artery into the leg, the doctor may perform a common femoral artery endarterectomy, in which he or she removes the plaque causing the blockage. Sometimes doctors perform an endarterectomy on blockages to the iliac artery in the pelvis. The procedure is performed with general anesthesia. The surgeon makes an incision in the abdomen or leg, temporarily clamps, and then opens the artery with an incision and removes the plaque, which is the waxy substance blocking the blood flow in the lower body. Then he or she uses stitches to close the incision in the artery and the skin. The surgery takes about 3 to 4 hours and typically requires a 4 to 7 day hospital stay. Then you will likely, or the patient will likely resume normal activities within 6 to 8 weeks.
Now for the nursing management. First, proper positioning.
Place the client's leg in a dependent position in relation to the heart to improve peripheral blood flow. Avoid raising the client's feet above heart level unless specifically prescribed by the healthcare providers. Another is keep the client in neutral, flat, supine position if in doubt about the nature of his peripheral vascular problems. Next is to promote vasodilation. So, provide insulating warmth with gloves, socks, and other outerwear as appropriate. Another is keep room temperatures comfortably warm. Instruct the client to warm himself with warm drinks or baths. Never apply a direct heat source to the extremities. Limited blood flow combined occur with normal circulation. And then teach the client about the vasoconstrictive effects of nicotine and caffeine, emotional stress, and chewing. Discuss ways to avoid or minimize these risk factors. Another is teach the client to avoid constricting clothes such as garters, knee-high stockings, and belts. So if over-replacement of glucocorticoid is indicated, inform the client about the purpose of therapy and possible adverse effects such as cosyncoid appearance, weight gain, acne, hirsutism, peptic ulcer, diabetes mellitus, osteoporosis, infection, muscular weakness, mood swings, cataracts, and hypertension. Another is promote activity and mobility. So for a client with decreased arterial function but without activity limiting tissue damage, encourage a program of balanced exercise and rest to promote development of collateral circulation. Now, in providing care for a client undergoing angiography or percutaneous transluminal angioplasty, before the procedure, provide information related to the procedure, validate that the informed consent has been obtained, mark peripheral pulses, obtain diagnostic data as ordered, and withhold food and fluids as prescribed. And then, for the after the procedure, maintain bed rest as prescribed, keeping the involved extremity extended, monitor vital signs, and assess peripheral pulses and circulation every 15 minutes for 2 hours, and then every hour for 4 hours. And then, assess for bleeding, hematoma, or edema at the catheter insertion site. Encourage oral fluid and monitor urine output. Another is let's provide care for a client receiving an autogenous saphenous vein or a synthetic bypass graft. So, let's prepare the client for surgery and mark the site of the peripheral pulses. Next is monitor the client carefully after the procedure, especially for the first 24 hours, for signs of graft occlusion as manifested by decreased arterial perfusion. And then anticipate and take steps to prevent complications of any surgical procedure involving general anesthesia, particularly respiratory problems and infection. Now, for providing care for a client who has received an axillofemoral or axillobifemoral bypass graft or an endarterectomy. Example is the removal of atheromatous plaque. So, avoid positioning the client on the side of the graft or incision after the procedure. Warn the client not to wear tight clothing which can lead to graft occlusion. Instruct the client on signs and symptoms of infection to report to the healthcare provider. Now for the patient education. So the nurse should educate the patient on lifestyle modifications and risk reduction techniques to prevent disease progression. This frequently includes smoking cessation, increased physical activity, and dietary modifications. Another is patients should get regular follow-up after every 3 to 6 months. If a prosthetic graft is placed, the patients should know that the risk of getting its infection remains there for the rest of their life.